This is actually all about the Determination trial. It was a real pleasure to present Determination on behalf of my colleagues to the Society, because it's the first presentation of these data to the IMS for sure, recognizing we presented data at the plenary session at ASCO this year and also the plenary session at the European Hematology Association. Just to remind people, Determination, designed over 12 years ago, in fact in around 2008, 2009, and we were looking there at a triplet combination therapy with either transplant used early or delayed, and critically lenalidomide maintenance given until progression. A distinct difference to our partner trial, which was the IFM DFCI 2009 study led by Michel et al. Our study, we sought to do exactly the same thing, but critically use continuous maintenance. This is a very important distinction between the two trials, and it probably explains some of the real differences that we see in PFS to date between the two studies. But above all, what we showed was a dramatic PFS gain using early transplant compared to keeping it in reserve, about a 21-month gain. What was really important, though, is we see identical survival between the two arms to date, even though 28% of the delayed transplant arm have actually had a transplant, with 72% actually getting other treatments. So this is incredibly important because it suggests that keeping transplant in reserve for selected patients, which was a basic hypothesis of the study, is a reasonable strategy in selected patients. Now, putting that to one side then, who benefits? Are high-risk patients helped primarily by transplant? And our standard risk about the same? Well, very interestingly, clearly high-risk patients did benefit from early transplant for PFS, and we show a trend, not quite at significance, but a trend to suggest there might be survival gain as well. Very important. Above all, what we show is that MRD negativity, however you get there, and even with high risk, is what you need to do. If you can get to MRD negative disease and you have high-risk cytogenetics, however you get there, either it's RVD alone or RVD with transplant, you do just as well, which is so important because obviously that's different to some of the other trials that have looked at a similar space, and probably the crucial difference is the continuous maintenance. We're very struck that maintenance until progression matters, and that matters in high risk as well as standard risk. So the Determination data were really very rich in terms of the information in it. We could talk to not only cytogenetics and risk, but also other new cytogenetic characteristics of interest, like translocation 1114 and 1Q, and we're continuing to look at those patients and analyze their data to inform the field. But I think a critical thing about Determination is the future. And what does it say? Well, clearly we met our primary endpoint. Transplant dramatically improved progression-free survival, exceeded our expectations, primarily I think because of the impact of maintenance. Now, where that leaves us though, is that we now have quadruplets. So the triplets we originally used performed well, but even with the quads now, things are even better. And we have higher rates of MRD negativity. So again, the use of transplant, clearly helpful, but like a lot of things, there's a downside to it, and we saw increased toxicity, a big hit to quality of life that recovered, and above all, we saw some secondary signals of long-term toxicities like secondary leukemia that were a little bit of a concern. So putting that all together, we're hoping to do better with the quads, use high-dose melphalan with stem cell support, recognizing its value more judiciously perhaps as we go forward, and arguably look at other strategies that get to the same core stemness that we're trying to get after or with the disease in terms of MRD negativity and all that means.